All
What
right,
kind of
to all who are
papers?
new here, my name is Dr. Michelle Henning, and I would like to
That's
welcome you
nice. I'm so
to
fruit.
Elevate
I'm good.
Virtual Journal Club,
You're telling if I
our
look
additional
at the
webinar
fruit line.
educational
The creepy
opportunities. You can visit our website and register directly for the webinar,
person.
or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedules, so check back often. This video will be available for review after this journal club.
No, but now I
The
can't
information
find where I'm
contained in the video
supposed to
content
be
represents the
on
views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the questions and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Emily Hart is a physical therapist who earned her Bachelor of Science degree in exercise science from Auburn University and her Doctor of Physical Therapy degree from the University of Tennessee at Chattanooga. She has worked at Cora Physical Therapy since 2019 and has also provided care in the rehabilitation hospital setting. She is joined in speaking today by Denise Overlock, who did her physical therapy assistant program at Saint Petersburg College. She has been the practice manager at Cora Physical Therapy in Winter Haven since 2013. Of note, she was also the Volunteer of the Year award, who was awarded last year in 2025 by Polk County Senior Games. And they are speaking today on rehabilitation of gluteal tendinopathy. Right.
Share and then switch over here.
Yep.
And start presenting
mode. Let's go back to this one. We're on the PDF that we were downloading and then slideshow.
I think that's what the one is. There we go.
Yes.
Perfect. All right. All right. So, as Dr. Henny was saying, I'm Emily Hart, a physical therapist at Cora in Winter Haven, and then Denise here.
Overlock from Winter Haven, Cora.
A clinic manager and a PTA. Disclosures, financial, we don't have any non-financial, like we just said, and Dr. Henny mentioned as well. We're employees of Cora Health Services. We consider ourselves Cora Physical Therapy is usually how we refer to it in the community. So in terms of this discussion, we're going to kind of get into the outline here in a minute that'll give you guys a little bit more of a heads up on what we're doing, what we're talking about. Obviously, gluteal dysfunction, but specifically what we're going to be talking about. Objective-wise, the three main things that are objectives are understanding signs of gluteal-related limitations, applying knowledge of exercises and interventions to address gluteal activation at different levels of patient abilities, and also to analyze if patients are progressing appropriately or require further assessment or intervention, especially considering that interdisciplinary care of ATCs, PTs, MDs, all of those different sides of everything, because obviously we're treating that patient as a team. So here's that outline that I mentioned. First, we're going to talk about identification of gluteal tendinopathy, both based on patient presentation subjectively and objectively, as well as the broken wing sign, which is something that was brand new to me. We'll get into that a little bit more. Then we're going to talk about research that's specific to gluteal tendinopathy and dysfunction. There have been 2 of those studies within about the last 10 years. We'll get into that. Then interventions, a really specific talk on education and functional focus of interventions and just those things as an important factor in patient care, as we all know, but especially getting into some studies, tying everything together in terms of those 2 things. And then also getting into those LEAP and GLOBE studies, especially talking about early intervention with those patients presenting with GT. And then also as progression occurs, because as we work with those patients, that's going to improve, that's going to get better. The patient's going to get more functional, more independent, and then how to kind of build on that. We'll get into that a little bit more. And then also kind of a final section talking about that assessment of progress, something called the VISA-G, and then also that interdisciplinary care that I went into a little bit more specifically here a few minutes ago. So this first section, we've got that identification of GT. You might hear me refer to it as gluteal tendinopathy, GT. You might hear me refer to it, or Denise refer to it as GTPS, gluteal or greater trochanteric pain syndrome, excuse me. Obviously, a lot of us have probably already seen this once, twice, dozens of times, hundreds of times, but getting a little bit more into these studies. Just for interest, part of how I got interested in this topic, and Denise and I were talking, is when I was in school, in PT school, I did a case study and a presentation on a patient with GTPS. And so I was kind of interested in seeing what else was out there in terms of interventions, assessment, all that kind of stuff. I worked with, in one of my clinicals, a PT from Australia, actually, who pointed me in the direction of some particular interventionists, physiotherapists, physical therapists, and so kind of built on that information. So first, kind of regarding that identification, we're going to be talking about patient presentation, especially subjectively. There was a cross-sectional analysis done by Grimaldi et al. In 2026 of a randomized control trial that we're actually going to talk about later in patients with confirmed gluteal tendinopathy. Participants were mainly female, average age of 55, which fits with that kind of primary population we're going to be seeing with GT, especially GTPS. And we were asked, or they were asked, excuse me, to name 3 activities that were most affected by that condition and by their symptoms. The most common activities reported were walking, running, and sitting, followed by laying on the side, gardening, cycling, and climbing stairs. And I wasn't super familiar with this outcome measure, but basically there are blanks and people can kind of write in what things are most affected for them and then check that at different time periods and check that kind of progress over time, continued limitation over time. Again, we'll get a little bit more into the RCT that this was kind of a secondary analysis of. Another thing they noticed in there, just for interest, was that the functional limitation effect on vigorous activities was actually found to be greater than the effect on less vigorous activities. Still want to focus on all those different things, but that was one thing that they found in terms of the degree of limitation. So then objectively, again, we're familiar with this condition, we're familiar with identifying it, but some specific information, I know there's a lot of numbers here, I'll kind of break it down a little bit. But basically kind of looking at those factors, there have been a couple more recent studies, again, that I wasn't super familiar with or wasn't familiar with at all, talking about some different things we can look for in these patients. I've actually already found this helpful with my patients that I'm working with right now. So the first thing is pain over the region of the greater trochanter may also extend down the lateral thigh in terms of that referral pattern. Per a study done back in 2024 by Kinsella et al., palpation of the greater trochanter was not completely adequate for diagnosis, though. You want to add in other testing, and what they found was that resistive hip abduction and then the 30-second single leg stance test in terms of pain with those activities were really important in terms of identifying those patients. So especially once you added in the tenderness of palpation over the greater trochanter and when either associated with either resisted hip abduction or single leg stance test being positive, it found that it was pretty accurate in terms of diagnosis and ruling out of things. You can look at that study for a little bit more information, but 96% and 99% when combining those things together. Something else that has been found is that individuals with DPS show hip abductor weakness bilaterally, even if they're only affected unilaterally, which especially becomes important down the line with that patient as you're progressing. Just something to consider. And then you also want to consider those differential diagnoses of pain, whether that's hip OA, referral from the lumbar spine, hamstring tendinopathy, just kind of assessing those patients for any differences between them. So that broken wing sign I mentioned, there was a study done back in 2025, so not that long ago, that specifically assessed individuals with suspected hip abductor insufficiency, specifically for gluteal tear and gluteal atrophy. There were a lot more data points on this. There was a lot more information, but I tried to kind of hit the most important things. Testing position is really that typical glute max strength test, but in terms of the rotation of the hip, that's what you're looking at to see what changes. And so that testing position in prone, knee and 90 degrees of flexion, and then lifting into hip extension, active range of motion against gravity. Negative is the test in terms of gluteal involvement, especially GT involvement. Negative when the patient maintains that testing position. More than equal to 10 degrees of hip ER was found to be positive for weakness of the internal rotators, and then more than 30 was found to be more specific and positive for a more severe pathology or tear. They actually compared this to MRIs to see how specific and sensitive it was in terms of ruling in, ruling out, all that kind of stuff. Those numbers are on that slide. And really the reasoning behind this is that the anterior fibers of the glute med facilitate IR. And so if those glute med fibers aren't acting correctly, activating correctly, you're going to get that external rotation. I have a couple pictures on the next slide, so that should help kind of visualize it a little bit better. And then you also want to consider, though, the limitation revolving the glute max with this. So it's just good to kind of pay attention to that. Here's a picture. Just of note, this is my husband. He is not positive on these tests. He kind of faked it for me, just kind of for that visual. He's also, and we'll get into this more, he's kind of the demonstrator for exercises later on. He is hypermobile in pretty much all his joints, especially his knee and his shoulder blades. And so some of the images might look a little wonky, is what he wanted me to tell everybody, because it might look a little weird. But he was a great sport doing all this for me a few different times in a few different pictures. So anyway, negative test, lifting that hip against gravity, negative for that rotation, and then positive, you get that ER because those fibers aren't acting correctly, whether there's a severe tear, a slight tear, whatever. He kind of did between the 10 and 30 range. We didn't simulate the excessive motion, partly because I thought that he might get too much movement of other surrounding joints when we did the picture. So just for kind of visualization of it. So now we've kind of reviewed GT identification, that broken wing sign, that's a new for identification, possible identification. Now we're going to be getting into some research, including a couple of RCTs, especially one that I just mentioned back at the beginning of the PowerPoint, specific to GT. So first study we're going to review is one by Malor et al. That was completed in 2018. It was referred to as the LEAP study. That is not on this stage this slide. So this page is talking about the 18 study, which was actually the RCT. There was also a protocol article written back in 16 that kind of prepped and went into more detail on what exactly was in the study, and it was referred to as the LEAP trial there. So if you hear me say LEAP, that's what I'm referring to. What this study looked at was individuals who met the clinical diagnosis and MRI confirmation for gluteal tendinopathy. They were all between 35 and 70. They'd had lateral hip pain for more than 3 months. They had pain intensity of greater than or equal to 4 on a scale of 0 to 10. They had a clinical diagnosis of gluteal tendinopathy by a physical therapist, and then information was confirmed by MRI. This RCT was designed with 3 different groups, EDX, CSI, and WS, standing for Education and Load Management and Exercise, single corticosteroid injection, and wait and see approach. Obviously, we're ATCs, PTs, MDs, we believe in this stuff, but this study actually looked into that a little bit more to see, okay, what combination of things seems to be best, or at least in the case of this study, what seems to be best. So then we've got this RCT protocol with 3 groups. This is where I explained, referred to as the LEAP study. We'll get into more specific information about the exercises. Like I mentioned, my husband kind of showing us some different exercises later, but now we're going to kind of focus just on this study and what it found. So that EDX, that education and exercise group, that involved 14 visits completed over the course of 8 weeks. Visits included education specific to the tendon, tendon loading, tendon care, and then gradual progression, as we're going to be looking at with our patients. They were provided with an AGP of 4 to 6 exercises that were performed daily, mostly focusing on hip adductor strength, but also dynamic control of hip adduction during activities. And then it also involved later on, and there'll be a chart later to explain this, 2 times a week of heavier loading exercises that were actually supervised by the therapist. Not all were at all times. Then you have the group that was treated with a single corticosteroid injection, and then also wait and see group where they had 1 visit for education related to, again, tendon care, loading, progression, that kind of thing. And then also just talking to them about education that usually gets better over time, but just kind of seeing, okay, with that 1 visit, how did that 1 visit of education versus education plus exercise, unsupervised or supervised, affect their progress? And then we also get into a little bit importance of education, which will be addressed later. So when they compare different groups in this study, the 2 main primary outcome measures that they looked at were GROC, or global rate of change, as well as pain intensity. They looked at these individuals at 8 weeks after the study started, as well as 52 weeks, so a year. What they found at 8 weeks, it was that in terms of their improvement, in terms of their global rate of change, things were better, results were better for the education and exercise group, more than the corticosteroid group, more than the wait and see group. And then at a year post, global improvement was greater for EDX compared to CSI. So education and exercise compared to corticosteroid injection. When they looked at pain intensity, at 8 weeks, pain intensity was lowest for EDX compared to CSI compared to wait and see. And then at a year, actually, so that longer term, although global rate of change was more for EDX than CSI at the beginning, in terms of global rate of change, a year out, they were actually equal. So just some good information in terms of that medical intervention as well as that clinical intervention. And then at a year, pain intensity was lower for both education and exercise groups and the corticosteroid than wait and see. So as you can see with those numbers, I know that's a lot of information. But EDX and CSI were both found to be more helpful than wait and see overall, though there were some differences, especially at that year mark. It also utilized the VISA-G scale, which we're again going to get into later. That was just a secondary major, so metric, and so I didn't go deep into that, but we'll get into that and kind of that importance later. So then this other study, we had that LEAP study, and now we have the GLOBE trial. It's just named for this Gluteal Tendinopathy University exercise program. It was an RCT design with 2 groups out of the 3. There was the group doing the GLOBE exercise program. There's also the group doing a sham exercise program. We'll get into that a little bit, but and the differences there. All participants were provided with a booklet in terms of education, activities to avoid, and then also adjustment of static positioning posture. So trying to avoid sitting with legs crossed, trying to sleep without those legs crossed in adduction, or at least touching an adduction, not hanging on one hip when you're standing, all that kind of stuff, kind of sitting in neutral, trying to take the stress off of that gluteal musculature. So what this involved with in terms of protocol between those 2 groups, there was a therapist-initiated AGP, which involved 10 to 15 minutes of exercises completed twice a day for 12 weeks versus daily in that other group. And then depending on the grouping, how many times they saw the therapist. They were reviewed and progressed at 4, 8, and 12 weeks in terms of intervention. That GLOBE group, so the treatment group, involved a 4-stage exercise program, and it focused on isometric loading of the glute med and the glute min in the kinetic chain, versus the sham group was a 4-stage exercise program with seated exercises, not really focused on loading of that glute med and glute min or the kinetic chain. And so we're going to get now into that comparison of the outcomes. They actually found lack of treatment effect between these 2 groups, interestingly enough. Both groups improved, which is great. Obviously, we want our patients to get better, but both groups improved with no difference between the randomized groups, either at short or long term. And those short and long-term follow-ups are pretty similar to that LEAP trial, though there were certain individuals within the responder group in the GLOBE group, meaning people who did respond to intervention within that GLOBE group, who did show improved outcomes. So there might be, even though between the treatment group and the sham group, at baseline in terms of comparing, they both got better. There's a group of responders within that GLOW group that might show that there is a positive finding in terms of those exercises. It didn't really get into that a whole lot more. It's just saying, hey, there's some open-ended information that we might be able to get into a little bit more later. And again, this also utilizes that BCG scale, so we'll get into that at the end. Okay. All right, so now we're getting into interventions. We're going to start talking, I kind of alluded to this earlier, I mentioned this earlier, we're going to start talking about those initial interventions in terms of patients who are more symptomatic, closer to the beginning of care, all of that kind of stuff. And then we're going to get a little bit more into progression. A lot of the progression, just as kind of a caveat going into it, a lot of the progression-based section is going to focus on studies that looked at max activation of these glute muscles. Obviously, there's a period of time in between there that we want to work with our patients and build them up. I didn't find a whole lot of research, at least that I found, on that kind of middle grade, but a couple of these studies that we're going to get into later that focus on that max activation of glute med, glute min, some glute max, some other muscles. They did have some exercises that didn't show that max activation. So it's just good to be able to kind of see those tiers of what to do first, what to do as we progress, adjust as you can, as you need to. I have in here to talk about my husband and his 4-month stuff. So just again, keep that in mind in terms of the exercises, but I really had pictures in there just to try to kind of solidify everything. There's a lot of studies in here. There's a lot of information. So pictures can just kind of help it make sense a little bit quicker. I kind of try to give pictures of the most significant findings of each study. All right, so in terms of intervention, I want to go over a little bit more specifically, and I'll skip to the next slide for a second, education and also functional movement training, because a lot of these studies that I'm about to get into involve both of those things. We already talked about that in terms of the LEAP and GLOBE trials, in terms of the importance of education for both groups or for both studies. One thing that, again, that education really focused on, especially in that LEAP study, from what I read, was that load management. We really want to talk to those patients about having appropriate load, both enough load, but also not overdoing as well. A couple of studies that I highlighted here, one of them is that there's a considerable effect of high tensile and compressive load, especially when repetition is involved, whether that's positioning or activity. Also, having low tensile and compressive load can also limit their capacity to load. So if they're not loading enough over time, those tissues aren't able to tolerate what they need to. And so then maybe when they try to progress, they're not able to do quite what they would have been able to if you had lost that. That also points back to some degree to talking about how with GT, one of these studies found that people tend to have, or individuals tend to have, weakness in both abductors, even if only one is affected. So just kind of considering that overall tolerance in the whole person, not just that specific body part, as we all know. And then also just the importance of progress activity gradually. Again, we kind of talked about that with the trials in terms of education to patients to do that slowly and do that based on their body's improvement. And then functional movement training. We talked about education related to tendon compressive loading and functional activity completion. So that tendon compressive loading, but now in that functional activity. Hip abductor strength deficit, already just talked about that. And then something else just to note is limitations of gait and other single leg loading tasks or single limb loading tasks. One of the studies I looked at said that individuals with gluteal tendinopathy have a higher hip adduction moment and altered kinematics of the lumbar spine and pelvis within gait. This isn't in here, but another thing I was reading by one of the primary studiers over in Australia, she talked about how in some things she looked at, gait wasn't always or not necessarily always addressed with patients. And so just something to think about functionally as well as gait related. And that first study I talked about way back in terms of subjective patient presentation, talking about how people, especially with walking, running, sitting, those were some of those, or were those primary activities that people reported difficulty with. That the response is talking about walking and running being two of those three main activities that were limited, shows that importance of addressing gait training, gait assessment, interventions, all of that kind of information. So this is a chart for the LEAP trials. This came from the protocol article back in 2016 related to LEAP trial. I won't go into every single bit of this, but there were kind of 4 stages. You had week 1, week 2, weeks 3 through 8, and then weeks 3 through 3 through 8, those were that bottom section is the particular supervised exercises that were kind of higher level. One of the kind of schematics I saw of someone reviewing this article showed basically 4 different sections. You've got low load isometric, like static abduction, supine standing, a bridge section with progressions within that, functional loading, mostly with squats within that, and then abductor loading via frontal plane movement that started with sidestepping and then kind of getting more dynamic. Something I saw, one of the authors of that study and one of the researchers in that study actually showed incorporation of things like step ups. And there was one other thing that I can't remember off the top of my head now, it might be right here. It also showed step ups, and I can't remember if it was, I want to say single leg stance, that I didn't see actually in the protocol of the paper. And I also didn't see it in terms of the information in the 2018 actual study. So I left those out. Those could be things just to kind of consider, even just thinking about functional loading, adding in that single leg, adding in single leg balance, adding in single leg with step up, just something to kind of consider. All right, so this is just kind of a schematic of that week 1, what things you might include. This is a double leg bridge, squat. One thing we really had a hard time with Corbin was not getting that anterior pelvic tilt, so we worked on this. Was about as good as we got, but he was able to apply the information, which was good, and then also sidestepping. And then that week 2, we have an offset bridge, and then also an offset squat, as a couple of things involved there as that patient progresses or those individuals progress. Then we have week 3 through 8, single leg bridge, single leg squat, and then side slide, with band. And again, in that one, we get a little bit of a pelvic drop, but he's a good sport about it. And then those supervised exercises, what we always refer to in our clinic as a Pilates table. But in terms of how they refer to it here, I'm going to go back here. Sliding platform with spring resistance, just kind of describing. I didn't want to not explain it specifically. But getting that both in terms of abduction motion as well as abduction during a squatting motion. I tried this. Actually, it was pretty challenging. It was more challenging than I thought it was going to be. And then globe. So we reviewed this earlier, but globe, in terms of the globe interventions versus the sham exercises, not a whole lot of difference in terms of that randomized inclusion of patients and individuals in those 2 groups. But I still wanted to kind of go over what they use, just because these things can still be helpful for glute med activation, tendinopathy, hip. You've got hip hitch, single leg squat, like we talked about in the last study, sit to stand. They included calf raises as well, just some ideas in terms of interventions, even though between those 2 groups there wasn't a whole lot of change, just some things to consider. So now this is going to kind of get into those studies looking at max activation of glute, especially the glute med. Some of these include glute max, quad. One of them had biceps femoris. I'm not going to get a whole lot into the details of these. All of these were pretty accessible. A couple of them one of them I know for sure was from when I was in school, that I still use information for clinically that I've seen work. I don't have proof of that, obviously, other than the patients improving and kind of those objective measures, but I wanted to include that just because that was pretty important for me, especially as I was starting out as a clinician. And then we'll get into a little bit too of those kind of intermediate exercises between when they're new to GT and new to treatment, and then or those max activation. So this DiStefano study back in 2009, so I can't believe it, but that's been about 17 years. They used service EMG for both the glute med and the glute max. Patients did 8 repetitions of each exercise with 2 minutes of rest between them. We used all these different things: clamshell, side lying hip abduction, single leg squat, single leg deadlift, lateral band walks, lunges in each plane, and then also hops in each plane. And what they found was, in terms of the glute med, there were clear tiers in terms of max activation and then not quite as much activation, especially regarding MBIC. Side lying hip abduction actually yielded 16% more glute med activation than any of the other top tier exercises. So just kind of going back to, yes, that's non-weight bearing, but lifting against gravity, typical glute med testing position, just kind of that importance there. His form actually looks pretty good in that exercise, so that's good. That's a plus. And then that side lying hip abduction had 30% more glute med activation than the lower tier exercises. And so again, that side lying hip abduction the most, but then also within that top tier, still pretty good in terms of MVIC of that glute med or side lying hip abduction, single leg squat, band walk, single leg deadlift, and sideways hop. So still pretty good in terms of that activation. Then in terms of glute max, it wasn't quite as clear in terms of tiers for this. Basically, the study found that single leg squat and single leg deadlift activated the glute max at more than 50% MVIC and 10% more than all other exercises. So I highlighted these two here. They were pretty specific in this study in terms of how exactly the deadlift and the single leg squat were done in terms of hand position, reaching, pelvis position, all that kind of stuff. We had originally taken pictures that were a little more general, and we try to make it a little more specific. So that might be something different about this study, just to pay attention to that specific position of the hand reaching to the opposite side. I don't necessarily teach patients it that way, but it can be helpful. And I'm going to go down just a little bit on my notes here. I just kind of highlighted here in terms of the glute med and glute max, looking at those other tiers. Something else to pay attention to, and this was something I learned in school, still use it with patients some, but clamshells. This study actually looked at clamshells done in 60 degrees, I believe 30 degrees as well. I think it's right here. Just didn't really get that glute med. Doesn't have that pure abduction movement and moment. You're getting a little bit of that rotation. I'll still use it sometimes, and this is just my kind of personal experience with patients. I'll still use it kind of as a step toward that side lying hip abduction. I have a particular patient right now who I don't know still if he would tolerate side lying hip abductions. But clamshells we've used as kind of a starting point, and he's getting stronger, he's getting better, so we continue to include that just based on how he's tolerating. Another study also a while ago, even older, 07. This study also had surface EMG, but instead of just looking at max med and then also VMO and biceps femoris, it added that VMO and biceps femoris. They did 3 repetitions of each exercise, 1.5 seconds for each portion, concentric and eccentric activation. They looked at unilateral wall squats and mini squats, forward and lateral, and retro step-ups. And I just wanted to kind of highlight this because we, again, talking about that whole person, the whole lower extremity, that whole kinetic chain, I'm just considering that quad and the hamstring in that as well. All 5 of those exercises involved both the squats and the step-ups, demonstrated mean in, I guess I'm supposed to say NMENG, but single amplitudes appropriate for strengthening the max, the med, and the VMO. Wall squat yielded highest activation for those 3 muscles, and so I highlighted that here. They didn't really find the same activation level for that hamstring, which makes sense in terms of the positioning and that kind of thing for the exercises, but just something to note since they did look at it. This study was done in 18 by Moore et al. It actually had the intramuscular electrodes, and so you didn't have to worry quite as much of effect of other muscles because of that surface. You had it actually in that muscle. They did 3 trials of 6 repetitions for each exercise with rest in between. Exercises were completed in random order. And I really just kind of included this information in each slide just to kind of give you guys in terms of the individuals and athletes that you're working with being able to kind of recreate these things, because that could be important in terms of the findings they had. They had these 6 exercises. I won't read through them this time because we're about to get into them a little bit more. They looked at the glute med in terms of the anterior, middle, and posterior segments. So especially if you know there's an issue with one of them, or just kind of trying to get each part in terms of the anterior glute med, single leg squat, bridge, and then resistive hip abduction, extension motion, and standing were the best for the anterior. And then posterior was the same in terms of that resisted standing hip abduction, extension, and single leg squat, but with that side lying hip abduction in there as well. We've already highlighted a lot of these exercises to be important, but just kind of another justification for that. I told him he looked like he was dancing in the first photo, so that's why he's laughing on that one. Anterior, posterior, I highlighted those 2 that overlapped between the anterior and the posterior segments of that glute med. Still not perfect on form, but you get the idea. I think he was pretty worn out by that point. This last study that I have, we did not try to recreate these exercises. I really encourage you to go to that article and look at it. It had a little bit more higher level type testing and then intervention. Compared traditional strength training exercises with acceleration specific exercises, and how they refer to that in the study was that it was focused on ipsilateral hip extension during contralateral hip flexion, so controlling that motion essentially. Looked at peak EMG activity. It did involve people and individuals who were trained in terms of exercise. It wasn't something brand new to them. They at least had a little bit of basis versus, I mean, a lot of the patients we see, they come in really almost no experience sometimes. And so they kind of looked at that higher level. They did block exercises. So either glute med, glute max, they blocked those exercises together, and they only completed one set of form was accurate in that first one. So just that 1 rep max sometimes. Traditional exercises and acceleration specific exercises, they compare to hip thrust and split squat to resisted knee split and half kneeling glute squeeze for glute med, and then side plank with a combined leg abduction, resisted side stepping for traditional exercises compared to resisted prone hip abduction and isometric clam. Again, I would go look at these. A couple of these actually were not familiar to me, so I'd go look at these on the study that's referenced at the end of the PowerPoint. For glute max, they compared the split squat. So I'll go back here. So that split squat in the traditional exercise section, what they found was the resisted knee split had higher peak activation with a large effect comparatively, and the half kneeling glute squeeze with moderate effect. And then in terms of glute med, that resisted prone hip abduction. So again, this time I'm kind of switching how I explained it, but the acceleration specific exercises resisted prone hip abduction for glute max, had significantly higher activation with large effect compared to that resisted split squat on the traditional exercise side, and then significantly higher activation as well with moderate effect though relative to the side plank. And so just kind of explain a little bit more in terms of comparing those exercises. So that kind of finishes up going into interventions as we started specific to GT, as well as once that patient progresses. And then again, you can kind of look back at those studies to see those intermediary exercises that may not have maximally affected that glute med or glute max or whatever muscle that we were talking about, VMO, biceps femoris. But then getting a little bit more into kind of that intermediary, and then also kind of adjusting those different exercises based on the patient. So Denise is going to get more into this assessment progress, and this is that VISA-G that I mentioned. A couple of those studies used as a secondary measure, the LEAP and the GLOBE. So just getting into that a little bit more. This was another outcome measure that was not familiar to me looking into this. So this was a really good find. I think I'm actually going to use with a couple of patients as well.
You have that still or no?
It should be there. There you go.
So talking about exercises in the GLOBE and the LEAP, we just kind of want to remember to make sure that you're assessing them and reassessing what's going on, seeing that they're going their level. Obviously, as an ATC, you're going to see a much higher level of athlete than we will in the clinic. Most of the time, we're seeing patients that have had very little exercise or have no exercise programs in their life during their entire life, much less what's going on. But again, just seeing the exercises and readjusting them for the athlete so that you're getting the right amount. So severity, the biggest thing with is trying to get the patient to get, closed chain as much as possible versus staying open chain. Yes, you want to do hip abduction. We also do it a lot of times where the patient is against the wall. So they're actually literally, they're not making compensation. So you're keeping it in pure plane. So make sure that you're keeping that in that position, not allowing it to get hip flexion in there, trying to keep pure muscle activation for that in the glute med and glute activation. Let's see what else I got there. So if the patient continues to have, if your athlete continues to have pain, so they've returned to sport. So at this point, their tendinopathy is not so severe that you're actually allowing them to practice, and they practice through it. and they return to you and the pain has returned to the same level, making that determination of when you need to go back, again, pulling them back off the field, working more, trying to keep them in the game as long as you can, but also making sure that you're making the right adjustment to when they need to come out, when they need to come, maybe possible for an injection with a doctor, possibly coming back out, just doing treatment and not doing practice and sport, just focusing on treatment to get that pain down so that they can return to sport, hopefully by the end of the season, and not be out the entire year and not play at all. So again, just kind of assessing that patient regularly and making sure that you're adjusting that strength so that if they're doing the band exercises, that you're doing it resisted with both directions, both adduction as well as abduction as both, as well as single leg stance, jumping in multiple directions. So the single leg hop in 4 different directions, not just the forward or just the back, but doing all 4 directions. Then we progress it to where they're actually jumping over an object. So making sure they're actually laterally jumping over an object, not just purely to the side. Make sure you're jumping flexion up over the object. And again, don't get that much more activation. Again, maintaining that alignment is what Emily was talking about, is in that slightly internal rotation, is making sure that jump was created in that correct plane and muscle activation to the best of their ability. That was all the exercises I was talking about, making sure that we kind of talk about what was out there new, but also making sure that we are progressing the patients as fast as we are able to. You guys, when they're not progressing, then you're able to send them to the doctor, which in turn may send them to therapy or right back into doing some athletic training, conditioning stuff, and then get you back out to the field. I want to open it up for anybody who had questions. The time for patients
are out.
Clamshells.
At least for max activation.
Yes.
That's still something to consider when you're kind of working, but yes.
For sure.
At the very beginning, maybe when they're really, really painful, but other than that, probably not.
Don't love it.
Yeah.
Funny joke. My question is, you talked a lot about how if they have weakness, you're most likely to have adduction weakness on both sides.
Abduction
Do you
weakness,
treat
but yes.
both bilateral, or do you just treat the trouble pain side?
Go ahead.
We tend to tell them, so we're making them walk in both directions when they're beyond to the resisted band, when you're doing that type of stuff. So we don't do it in essence. I assess the pain on the other side, but I'm not really treating it. Most likely it's not pain, it's just weakness. So in the exercise program, we make them do both. They also don't tend to stay there very long because they do not like laying sideline. I was surprised sleeping on sideline was not like one of the first ones, because they are all complaining about that. Like, do I have to get on the table? Do I have to do that? Like, they really avoid lying on their side as much as possible. So you want to assess and strengthen both sides dynamically as high levels, much quick as you can.
And I don't necessarily have, like, in terms of the research that we looked at, anything specific of that, but just experience wise.
Yes.
Initially I may not, and maybe I'll start doing it now with kind of finding that hip abductor weakness is found to be bilaterally. Maybe I'll start doing a little bit earlier because I should consider them as a whole. I even think specifically, like, when I assess somebody's gait, looking at that hip drop, if there is one, if there's any kind of compensation in terms of that Trendelenburg as well. That may not be positive. They could still have pain or strength deficit even with being able to do that. Maybe I'm not catching all the compensations every time or whatever, but I may start doing it a little bit earlier. But I personally am usually starting in terms of that hip, especially in a couple patients that that'll actually work out.
Any other questions in the chat?
Okay.
Yeah.
But yeah, so for us, like, trying to be mindful of just trying to really see where the weakness is and adjust it. Be mindful that if they're single leg stance is one of the exercises that we do a lot. And then step taps, we do it in all 4 directions. Obviously, you guys are probably most likely doing it with a band so that the band is giving them more resistance. A lot of our clients aren't able to do that level. So again, adjusting to your patient real quickly. But again, just trying to give them the more resistance in that position that you can. And both directions, both sides. Same thing with the step downs. That's also really big. Again, watching the form. I think that's the biggest thing a lot of times, is that we change the form real quick. And it's not needing to. So we pull the mirror out and let them see it with the mirror. And it's weak. And so they just allow it to go in, and paying attention or lack of paying attention to it. We also do a lot of times, if they can't do a single leg squat, we'll do a band around them and work on their sit to stands with abduction. So really trying to get that activation, again, watching that alignment and not letting them roll internally.
Even leg press, at least
and leg press,
getting that.
We do a lot of leg press. Yeah.
Adding the band. I even do on our side fit, like stepper, sometimes putting that band around and have them focus on that abduction throughout the dynamic activity. Just kind of as that external cue, but also the resistance level as well has worked for patients, I find.
Yeah. Questions? See if there's any questions for you guys
on the side.
Don't think so. Good. All right.
Yeah, like see here, there's 72 people.
Wow.
Yes, indeed. All right, thank you everybody for coming. We're gonna, yes. Anna Lee asked, can you break down the visa? I should have it on.
Just 1 second, she'll pull it up.
There we go. I actually had this included in the slide and then I took it out. I was really, really careful on just making sure it's not pulling up. Let me see if I can Google it. Want to make sure I reference everything appropriately and accurately and didn't miss. Just pull it up. And a couple of others I found just as I'm looking for this. Visa for Achilles and then also patella. I think it was Visa P and Visa A, I believe. Again, things I hadn't heard.
So now we're studying.
Yeah.
Still trying to pull up.
And this is on that reference page, just so you guys have the reference here in your own. That was a specific study talking about development and validation of the Visa G, specifically to that gluteal. I still have it. There we go. Okay. So there's a question about usual hip pain, rating on a scale of 0 to 10, 0 being no pain, 10 being worst pain. Question number 2, I can lay on my sore hip. It basically breaks down a scoring of the amount of time that they're able to tolerate that, how long, what category that fits in. Walking up or down 1 flight of stairs, walking up or down a ramp or slope, after sitting for 30 minutes, basically how does that progression to standing and walking work? Working around the house or garden or similar activity if they don't do that. Then there's another question. This was kind of where it was broken down. I think maybe it's the next one. Question 7, are you currently taking part in exercise? And then there's one more question. And the question is, does your current hip pain affect your ability to undertake weight-bearing activities, whether it be walking, shopping, running, whatever? And the individuals answering then answer question A, question B, or question C. Yes, it's so severe that it stops me from these things. It's present with exercise, but it doesn't stop me from those daily activities. And then that third category and the answer again, one of these questions. If you have no pain, then how long are you doing these exercises? That maybe they're just not doing a whole lot of it. And then the score's taken out of 100 for a percentage. And that's kind of the breakdown. I found this just by Google Visa G, but it's that fear and how it was validated with that study.
Well, thank you everyone for attending, and we'll send out an email as we usually do after the webinar concludes, which has that quiz, evaluation, and assessment. Send that in. If there's any particular topics or speakers you want us to have in the future, we're happy to reach out to them to coordinate that, and then we'll see you again next month.